Dear colleagues, I'm very happy to finally be able to make a presentation on Dental XP, and I'm very thankful for the invitation. And today we're going to talk about zero bone loss concepts, the influence of vertical soft tissue thickness on crestal bone stability. But before we start, let me introduce myself. I am Tomas Linkevičius. I am coming from Vilnius, Lithuania, and currently I'm serving as an associate professor in Vilnius University. Also, I work in a private dental practice in Vilnius Implantology Center and as a director of research center in Vilnius Research Group. So, zero bone loss concept, what is that? Basically, it's a set of various factors which, according to our clinical experience, have some sort of influence on crestal bone stability. For example, the depth of implant placement, or from prosthetic point of view, screw retained or cement retained. These factors have influence of how bone is stable around our implants. And based on these factors, we have developed a series of lectures, and we could divide them into two groups, into development of crestal bone stability and into maintaining this stability, because one thing is to develop, but more important is to preserve the stability. And today we really will start with the first lecture, the influence of vertical soft tissue thickness on crestal bone stability. And here we're going to talk about soft tissues, implant placement, and implant design. But let me start with this picture, because I always start my lectures with this picture. And I always say that this is the dream of every dentist. Let's be frank, doesn't matter what kind of implant system are you using or what kind of surgery you're doing. This is the X-rays we would like that to have all of us. And when I show these X-rays to the doctors, usually two questions arise: what kind of implant it is, and what kind of doctor made this treatment. And the reason is that really these X-rays speak for themselves. When you show such kind of X-ray with a such stable bone, there is no question that the treatment is successful. Well, why crestal bone stability is important? Well, three major things: cortical bone for short implants, and also from aesthetical point of view. When we talk about cortical bone, we know that the cortical bone is much stiffer and much more stronger compared to cancellous bone. But during crestal bone resorption, we are losing this cortical bone, and sometimes this procedure may go on, and we may lose bone even further apically. So yeah, this crestal bone loss is dangerous because we never know, will it stop or will it continue like in this clinical case. Aesthetics. Of course, aesthetics is also a key factor, and crestal bone stability has a major role here. But I think not in terms of papilla maintenance, because we all know that papillas are maintained by neighboring teeth, but in most of the vestibular aspects. So when we lose bone, we actually have vestibular collapse, the tissues shrink, and sometimes you can see the situations like here. You can see the shining through of the implant itself. But the most important application is of crestal bone stability is in short implants, I think. And the reason is very simple, that when you have a longer implant, you can at least afford some bone remodeling. 2 millimeters for, let's say, 12 millimeter long implant is one thing. But for example, if you have 6 millimeters implant or 4 millimeters implant, so losing of 2 millimeters may be fatal. Like in this case, after losing the bone, actually implant is broken out of the bony housing, and we lose not only implant but prosthesis itself. And there is another factor which is more related to us as the clinicians. Just think what kind of treatment you would like to give to a patient, like this or like this, when you can see bone resorption. And if you would would be challenged with a question in which side you would like yourself and your patients would be, I'm sure that everybody would choose the left side. So yeah, crestal bone stability is very important. What about crestal bone loss? Well, when you look at these pictures, this is the picture, probably the first picture of crestal bone loss. It's been in 1977. And look, this is what we have now. So just think about it. It's 40 years of constant innovation. Implants have changed dramatically. New surfaces, new materials. Our prosthetics also changed dramatically compared to 14 years ago. But look, actually we still have crestal bone loss. We're still losing the bone, and this problem actually is not solved even after 40 years of innovations. And this problem was so common that indeed also now it's been considered as a normal thing to lose about 2 millimeters or 1.5 millimeters of bone loss after first year of function. And this is considered as a success. But we think that it's not success. We should do much more better than this. Well, of course, there is a myriad, really many factors which influence crestal bone loss around implants. But we are not going to talk about all of them, because majority of them are operator-dependent crestal bone loss. What I mean? I mean that if you do something wrong with your hands, for example, like here, when you have bad 3D position, when implant angulation is bad, doesn't matter what kind of implant you are using, you will have bone loss and you have recession of soft tissues. So these are things which are operator dependent. But sometimes you have done everything 100% correct. I mean, you have attached tissues, you positioned implant properly, the implant is okay, everything is fine, but you still lose bone. And just imagine that you start your follow-up with an X-ray like this. So I would like to be a patient or a doctor in this case, because you can see that you have already bone loss and it's just after delivery of the crown. So we will talk about what causes bone loss in these situations. Well, in my opinion, there are three most important factors to situations which I described. Polished implant neck, absence or presence of microgap, and soft tissue thickness. Well, what about polished neck? Well, polished neck was designed many years ago, and it was designed in the way of thinking that if you will lose bone, a part of the implant will be exposed, but the polished part will be exposed, and you will have less plaque or bacteria accumulation. But the problem is that the doctor started to place polished neck implants below the bone. And it's really now proven that if you place the implant with polished collar equally with bone or a little bit deeper, you will lose bone to the margin of the polished collar. And there are many studies who prove that. Another factor, microgap. When you look about the microgap, I think this is the most researched factor which influences crestal bone instability. There are so many studies, and all of them say that if you have microgap at the bone level, you will lose the bone. So what did manufacturers do? So they, of course, react to the research, and they started to produce roughened implants with roughened neck without polished collar. And for example, if you are using a traditional connection implant, they started to recommend to place implant supracrestally, in that way avoiding the positioning of bacteria inside microgap to the near place of crestal bone. Well, but we're still losing bone. Even though we are using these recommendations, we are still losing bone. And the reason is that we did not think about soft tissue thickness. So what is soft tissue thickness? Well, let's in the beginning decide that we are talking about vertical or crestal soft tissue thickness, which is measured at the top of the crest. And vertical soft tissue thickness is not biotype, when you can say it is a thin or thick biotype. Well, it's not horizontal thickness when you can measure it with a probe. And it's even not attached tissues, like in this picture you can see that we have attached tissues, but they are thin. So this is a completely new and separate parameter, and it must be measured vertically at the top of the crest of our edentulous ridge. Well, so why this crestal or vertical soft tissue thickness is important? Well, it is important because it is part of biological width around implants. I should say more precisely not the part, but from this vertical soft tissue, the biological width around implants is formed. It's sulcal epithelium, junctional epithelium, and connective tissue. And when you have a healed implant, which is completely integrated, there is soft tissue thickness is a barrier. It's protecting our osteointegration. So this is why our soft tissue thickness is so important. And well, God made us in that way that we have different scenarios. We have patients with thin vertical soft tissues, and we have patients with thick vertical soft tissue. And what I learned during the years that in different countries there are different biotypes. For example, in my country, Lithuania, the prevalent biotype is thin, that we have thin vertical tissues. However, for example, when sometimes we have patients from southern Europe, from Spain or Italy, we usually have thick vertical soft tissue thickness. So it's according there, it's very, very different. Well, and when people, because I've been lecturing with this topic for quite a while, say, well, you did something interesting, this is what was known before, I always start my lectures with quoting of this paper of Berlund and Linde, Dimensions of Peri-implant Mucosa, Biological Width Revisited, because they were the first to identify the influence of vertical soft tissue thickness on crestal bone resorption. And they did a really simple and nice experiment. They took dogs. In one case, they had thick vertical soft tissues, 4 millimeters, and around other implants, they just cut the half of the tissues, thinned them to about 2 millimeters, and then everything was sutured. And after healing, they found out that in test implants, which were positioned in thin biotype, they had significantly more crestal bone loss compared to control implants, which were in thin tissues. Well, but what is the problem with this study? Because it's a really nice study. Why do we need to talk about it? Because the problem is because it's an animal study. And when you look at the pyramid of evidence, animal study, it's only at the bottom of it. So even expert opinion, case report, or case series have more relevance to our clinical treatment than this animal study. So, of course, to make it more scientific, we must think about randomized controlled clinical trials or non-randomized controlled clinical trials. And this is the reason why we wanted to research this factor clinically. When we talk about crestal bone loss, two things are important. First, and we already have agreed on that there are many factors. But the other factor, the other thing which is even more important, that all these factors work at the same time. What do I mean? For example, if we take this kind of implant with regular connection and polished collar, and we put it equally with bone, what will we have? We will have all three mentioned factors working at the same time. And it's literally impossible to tell why the bone goes away, because of tissue thickness, because of microgap, or because of the polished color. So these factors must be somehow distinguished to tell which factor really is responsible for crestal bone instability. So the first question which we faced when we wanted to make a clinical study was how to isolate these factors. And we wanted to isolate microgap, polished collar, and then to research the influence of tissue thickness on crestal bone stability. And we managed to do that very simply, just to place implants supracrestally. In that way, to isolating those two factors which I talked about, and in that way we were able to test the influence of thin or thick tissues on this test implant, which was placed supracrestally, and then we were able to really evaluate the influence of soft tissue thickness. Well, and the results were really interesting, that in thin tissues we had significantly more bone loss compared to thick tissues, and you can see the numbers. And really, this was the first clinical study, first clinical evidence, and we published it in JOMI in 2009, which really stated that initial gingival tissue thickness at the crest is a significant factor influencing marginal bone stability around implants. Well, what about platinum switching? Because at that time when we were making the study, it was evident in the literature that if implants have platinum switching, they lose less bone compared to implants with matching connections. What is platinum switching in itself? And in itself, it's actually very simple. It's an isolation, it's a distraction of bacteria in horizontal way, in horizontal trend, because you can place implants supracrestally. In that way, you isolate microgap vertically, or you can use platinum switching implant. In that way, you isolate your microgap in horizontal perspective. And here you can see that it's over 150 papers now, which actually prove and claim that, yeah, implants with platinum switching lose less bone compared to implants with matching implant abutment connection. And if you look at the current systematic reviews, they all also say the same, that implants with platinum switching do better preserve crestal bone than implants with matching abutments. But is it really true? Yeah, when you start to investigate some sort of manner, you always find that it's not always 100%. At least these two papers, which are really at the highest level of evidence, they did not prove that there is an advantage in platinum switching implants compared to regular ones. And then you combine this knowledge with your clinical practice, you can start to have doubts. For example, there are two things in common in all this X-ray. One thing is that these all implants have bone loss, and the other thing is that all these implants are platinum switched. And you can have here Free Eye, Straumann, MIS, even Ankylos, which was considered as the first platinum switched implant. You can see they all have crestal bone instability. And sometimes you can have much better outcome with regular connection implants. Like here, you can see this is by Horizons, a regular connection implant, and it looks much better to the previous slide. And sometimes when you put two things together, you start to ask yourself, is it really possible that regular connection implant has a better outcome compared to platinum switching implant? And here I must want to stress one thing, that it is not operator-dependent issue. All these implants were placed by really skilled surgeons and restored by really skilled prosthodontists, and you can see that there is a difference. Well, the answer is actually pretty much simple and obvious. The reason is that, again, these two factors, soft tissue thickness and platform switching, was not evaluated in the same study. What I mean that there was no study which actually looked at platform switched implants, also having in mind vertical soft tissue thickness. And really, like 6 years ago, we made a very interesting study, a pilot study, when we took two implants, one implant with platform switching, the other implant with regular connection. We took patients with thin, soft, vertical soft tissue biotype. We placed them side by side according to all the manufacturer recommendation and restored them. And then we made an X-rays after placement, 2 months after healing, and after 1 year follow-up. And this was the first clinical evidence published by our group in 2010, and it showed that actually there was no difference between implants with platform switching and without platform switching if soft tissue thickness was thin. And this was published in Jones. However, this study is usually excluded from the systematic reviews because, this was a pilot study. We had only 6 patients and 12 implants. Well, having this kind of information, we started to apply to congresses, we made posters, but interestingly enough, of course, in the beginning, usually it's like that, there was no interest in that. And I started in the beginning to think that, well, maybe this is not really relevant. But some years ago, I received an email from my colleague, and he showed me some X-rays, saying, what do you think? And these X-rays really showed what I was talking about. Because here you can see that this is implant with platform switching, but it's placed in the thin vertical tissues biotype, and you can see crestal bone resorption just after delivery of the prosthesis. And it is not any implant system related. You can see it always if tissues are thin. You can see crestal bone loss just after restoration of the implant because of that. So that brought us the idea that we must somehow finalize this issue and to make a broader, a bigger clinical trial with enough patients, enough implants, and finally say what happens if we place implant with platform switching in thin vertical tissues. And we made a study. And our idea was to evaluate how implants with platform switching maintain crestal bone stability in thin or thick mucosal tissues. And we used bone level implants. We made a comparative study. We had an inclusion criteria that should be generally healthy patients, missing teeth in the lower back jaw area, minimum of bone width, healthy soft tissue, keratinized gingiva, meaning all the factors which could have additional influence on crestal bone stability were excluded. And before placing implants, we had a distinction. We made vertical soft tissue measurements, meaning that we made a crestal incision, we elevated buccal flap, and lingual flap was left untouched. And that allowed us a really good and precise measurement of the vertical soft tissue thickness because the flap was stable. And then after measurement, we raised the lingual part of the flap. And the threshold was 2 millimeters, according to the first animal study, to distinguish thick or thin tissues. So in thin tissues, the implant was placed equally with bone according to recommendations of the manufacturer, and this was one-stage surgery, meaning that healing abutment was attached and tissues were sutured. And the same was done also in thick tissues, the same procedures. And we waited for 2 months when the tissues healed and the implant was integrated, and then implants were restored with screw-retained restorations, again to eliminate another possible factor, cement remnants, from that it would not influence crestal bone loss. We had 4 measurements, 4 X-rays for each case: A, at the implant placement; B, 2 months after healing; C, after the restoration; and D, 1 year follow-up. And we measured as precise as possible. All X-rays were calibrated, and that made us, we wanted to make our results to be as precise as possible. Yeah, we had sort of statistics. Everything was done in a decent manner, how it should be, and the results were like that. We had 100% implant integration, but that was like, it was possible. We expected that because it was 1 year follow-up. And we had 40 cases in group 1 in thin tissues and 40 cases in group 2 in thick tissues. So what the results we had? First of all, tissue thickness. We had a significant difference between thick and thin tissues in general. That was statistically significant. But of course, our major interest was crestal bone stability. And here you can see how bone behaves around the implant from placement to 1 year follow-up. And you can see that already after 2 months, you can see the crestal bone loss, which continues and is stable loss after 1 year follow-up. Well, the question you might ask, why did we measure 2 months after healing? Because it is proof that biological width starts to form just after the connection of the healing abutment, and usually stops after 6 to 8 weeks. So already at 2 months, if you are supposed to have bone loss, you usually will be able to see it. Well, what's happening then in thick tissues? And in thick tissues, you can see that the bone is really stable, and this is the X-rays which we are used to see around platinum-switched implants. And you can clearly compare those 2 cases above and below. And then we calculated that was the significant difference at every measurement, at the 2 months after placement, at the restoration time, and especially at 1 year follow-up, that in thin group we have 1.18 millimeters of bone loss, and in a thick group we have only 0.22 millimeters of bone loss after 1 year follow-up. And when we looked at the measurements more precisely, that in thin tissues almost 95% of the cases had 1 millimeter or more bone loss, while in thick tissues almost 85% of the cases had only up to 0.5 millimeter of bone loss. It means that it's really consistent and stable results in both groups. Well, what we did next, we actually did a very interesting thing. Then we had all these measurements and calculations, and then we excluded those soft tissue factor. We just calculated around all 80 implants how much would have bone loss. It is usually done in all clinical studies which do not take into account soft tissue thickness. And what we got this 0.69 number, which actually does not say anything to you. And it's really, will you look very similar to other studies which showed that there was no difference with platinum switching and regular connection implants. Well, so now we go back to this 150 papers which actually show that platinum switching is effective. And I will say this, that none of these papers had initial soft tissue measurement. Well, my point is that maybe if there was this soft tissue thickness was measured at that time, maybe we would have some different results as we did in our study when we had two distinct groups. Well, and for the long time, I was wondering maybe why do only we get this kind of results? Why there is no any other publication of any other scientific group which would prove that we were right? But luckily, there is appearing already studies which prove that vertical soft tissue thickness is a really important factor. One of this is published in Belgium, and they made a really interesting comparison. They made a within-implant comparison to evaluate the concept of platform switching. Then implant on one side had platform switching and the other side did not, meaning that bacteria in one way were closer and the other way was farther horizontally for crestal bone level. And they arrived to the conclusion that platform switching is only effective when the mucosal tissue thickness allows the establishment of biological width. In other words, if you have thick tissues and biological width establishes, then platform switching can reduce crestal bone loss. Also, the other study from the same group was the same outcome, that they found that they had more bone loss around not high healing abutments, not high locator abutments, indicating that at the beginning soft tissues were thin. Well, the next question is, so why do we lose the bone when we have thin tissues? What is the pathogenesis of crestal bone resorption? Because etiology will already know that thin soft tissue biotype. And here I want to make a credit to Steven Chu. Actually, we've been working together on this issue, and the idea is that the plague or bacteria are responsible for that. Because usually there is always plague. There is always plague in our around our implants. And for example, when you remove healing abutment, you cannot see the plague. But when you color it with a revealing agent, you can find that there's a plaque even present below the gingiva. So if you have thin tissues, it means that you will have thin or shallow healing abutment of 2 millimeters, for example. And when you take out this 2 millimeters abutment, you color it and you always find there is a plaque present. So it means that if you have thin tissues, bone resorbs and runs away from the plaque, because the plaque is always present on the healing abutment. And this concept goes on that only must be safe distance between our plaque and healthy bone. From the other hand, if you have thick tissues, for example, 5 millimeter healing abutment, you can see here, it means that bacteria are higher and we have sufficient distance made of soft tissue thickness from bacteria to crestal bone level. And in that way, in thick biotype, this is the reason why we are losing less bone. And when you think that this is something new, you might be wrong, because already in 1952, in the works by Jens Weierhau, actually he proved the same concept around teeth. Because while he was researching extracted periodontally involved teeth, and what did he find? He found that there was the constant distance between subgingival plaque or bacteria and attachment fibers, and meaning that the inflammation continued. All this group was moving apically, but there's always distance. So this is the same around implants. If you have 4 millimeters of soft tissue thickness, it means that all your bacteria is in a safe distance from the crestal bone. And if you have thin tissues, means that bacteria are closer, and this is the reason why bone resorbs to create this sufficient distance of about 4 millimeters for the protection. So I think we're arriving to some sort of summary before we move on a little bit further. So what summary could be? That if you have thin tissues and if you have implant with planar switching or implant without planar switching, you are going to lose the bone. If you have thick tissues, then again it doesn't matter what kind of implant, your bone will be much more stable. Only one thing, that in planar switched implants you can place them equally with bone, while in regular connection implants you must leave them above the bone, because the microgap, the bacteria in microgap or polished color must be taken away in horizontal direction from the bone of the crest of the bone. And what is the relevance? We talked a little bit in the beginning, but in my point of view, the most relevant thing is for short implants, especially now when short implants are very popular. We have already now 4 millimeters of 4 millimeter short implant. So imagine 2 millimeters of bone load, it's a half of the length. So it can just break out of the bone and you will lose the restoration and the bone. So when we even talk about this kind of implant and this kind of restoration, also this implant done in this interesting manner also needs some sort of vertical soft tissue thickness for the protection. Well, when I'm usually presenting this topic, I always get a question. So, is there advantage of platinum switching? Do we still need these implants? Maybe we could use the old implants with all connection. And I always say yes. I always am for platinum switched implants of various reasons. First of all, we have better emergence profile with this kind of implants. We have more soft tissues, and still we have less bone loss. For example, here on the left side you have implants with platinum switching, which you can see more tissues, and on the right hand you can see a regular connection implant. And as a prosthodontist, and you can ask any prosthodontist which kind of implant he would like to restore. And of course everybody will say that he would like to restore the left one. And when you look at the numbers, still we lose less bone around platinum switching implants. Only there is one distinction and one thing which we have proved, that if you have thin tissues, you will lose bone around platinum switching implants. But if you have thick tissues, you will lose less. The same with regular connection implants. You can see that even in thick tissues, if you have implant is placed above the bone, you still lose a little bit more bone compared to platinum switching implants in thick tissues. So anyway, I think platinum switching is a good concept. However, we must not rely only on technology or design of the implants. We must also think about biology. And soft tissue thickness is a biology. Especially where you can use immediate platinum switching implants, immediate placement. This is a really good application of platinum switching implants. It means that you can place your implant a little bit deeper to have better stability and later to have better emergence profile compared to regular connection implants. Well, we talked about what happens in different scenarios, in different soft tissue thicknesses. Let me show a little bit just before the end what could happen if you have bone loss even in thick tissues. Like here, that the protection, the thick, vertical soft tissue thickness is so important that it's really one of the major factors which influences the outcome of our implants. And I want to share with you a few cases where we actually saw the potential of thick vertical soft tissues. Here is the case. Implant was placed, you can see equally with the bone, and regular connection implant. When the implant is healed, we started the modeling of the soft tissues with provisional. And already you can see there is a bone loss present. And the bone loss is here not because of the tissues, but is because of platform, because of the microgap was placed equally with bone. Actually, bacteria was at the bone level of the bone. And this is the reason why the bone resorbed. However, we proceeded. We managed the tissues. Look how nice they look. We restored the case with zirconia ceramic crown, and see what happened later at the placement, provisional, at delivery. 1 year follow-up, you already see the changes. 2-year follow-up, but look at this, 3 years follow-up, and you can see the remineralization of the bone. The bone doesn't grow back, as we say. It's not the growing of the bone, it's the remineralization of the bone. And I think that we can observe this only in thick tissues. When the protection is sufficient, when we have sufficient distance between bacteria and the bone, and when we have a good restorative material, sometimes you can expect things like that. And you can see it's really, really, really nice. Another thing which we noticed in thick tissues, it's a corticalization. When you can see that it's the thickening of the cortical plate of the bone. You can see in the picture that it's much a little bit whiter in an X-ray. It means that it's more dense. And again, we observed this phenomenon only in thick, vertical, soft tissues. So, at the end of the day, I'd like to say some take-home messages that are most important from all this lecture. First of all, vertical soft tissue thickness is a separate measurement. I mean, this is a separate factor, and we must do it and we must think of it when we are reading the paper and when we are designing the study. Study design must include evaluation of soft tissue thickness. After this, if there is no soft tissue measurement, you can always challenge the results of the study. Platform switching implants do not prevent bone loss. I mean, if you have thin tissues and you will place platform switching implants, you will have bone loss. And if you have thick tissues and you will place a traditional connection implant, you will have less bone loss because tissues are thick. But also what is important, you must place traditional connection implants a little bit above the bone to isolate other two factors, polished collar and microgap. So if you are a scientist and tomorrow you are thinking of designing starting a study which would evaluate Crestal bone stability, you must do this. You must evaluate, you think about vertical soft tissue thickness, because we showed it in our results that it may dramatically change the outcome of the study. So with this nice pictures, I want to finish the first part of zero bone loss concepts. And here we arrived to this X-ray and to the question, well, we know that thin vertical tissues is not good, but what can we do about it? And what can we do about it? We will learn in the future. And here I want to stop. I want to finish my presentation, and I'm very thankful again for Dental XP for giving the opportunity to present this to you. Thank you very much.